Hey guys, Woodruff here. So we are blowing through this EKG section. I know you're so excited. Now we're going to talk about sinus bradycardia and treatments and stuff related to that. I'm going to change my pen color. I know that, if you're not a fan of my new pen usage, I apologize. But I think it helps with this section. I promise I won't use it for others unless necessary. So we just talked about normal sinus rhythm. I'm breaking down this PowerPoint into each rhythm versus going into what do you call it? Having like I think usually I group them like sinus rhythms, then I have atrial rhythms, blah, blah, blah. But I'm going to try to do rhythm by rhythm this time. So anyway, let's talk about sinus bradycardia. We just left off at normal sinus rhythm where everything is normal, except that everything is normal and there's nothing abnormal. So now we're going to get into everything is normal, and that's what sinus bradycardia is. So again, like I said, for all rhythms, first go and see, do I have a P wave before every pointy thing? Yes. Do I have a pointy thing with every beat? Yeah. Or so I should have a pointy thing after every hill? Yes. And then do I have this T wave present? Everything's upright the way it's supposed to be. Awesome. And skinny QRS, perfect. So everything is normal here. I have all my parts. Oh, and then also it's regular. All the space in between this, it's all the same distance. So there's nothing off here. I know my arrows are always off, but same distance here. And so if everything is normal, what's different about sinus bradycardia? What's going to be different is going to be this rate that's less than 60. So with sinus, it's still my sinus, pacemaker in my heart that is sending the signal, but it's just working a little slow. Remember, normally it operates at 60 to 100, but in sinus bradycardia, I'm going to have a rate that's less than 60. Everything is normal, except I'm a little slow. And I don't know why, but it almost felt like that hurt my feelings when I said that, because sometimes I feel a little slow, but it's all good. Anyway, so there can be normal reasons for your heart to be going this slow. If I was a very athletic, in shape person who ran marathons or, a competitive athlete, my heart is used to operating at a lower heart rate. For people that are competitive or professional athletes, and you don't even have to be like, I don't want to make it sound like you have to have some sort of crazy competitive edge. And most athletes, or even people that are generally, keep pretty healthy, can operate on a lower heart rate. So their resting heart rate might be a lot lower. So this might just be what some people's normal is. And it doesn't really affect them because their body has learned to compensate for it because of their regular exercise. And then also in sleep. So if you're one of those people who sleeps with your Apple Watch or other watch, and then watches your heart rate trends while you're sleeping, you may notice that your heart rate gets low overnight. You might be like, "Ooh, it's super low." Well, it does go down because when you're sleeping, your heart rate doesn't need to be elevated. You need less cardiac output. Your body's resting and digesting. So it depends on the time and then the patient's history, but there can be abnormal reasons or issues. Like, for example, we just got through all the cardiac meds and hypertension meds, and we talked about how beta blockers can decrease your heart rate. So sometimes someone could have it, and it could be expected. I told a story about a student that I gave a beta blocker with whose heart rate was like right at 60. And we looked at the parameters, and they actually said that they were okay with it being only need to hold it if the heart rate was less than 55. So everyone's different. Some doctors might be okay with their patient having a heart rate between 50 and 60. Just know with beta blockers, like, the goal isn't to get below 60 usually. If it gets below there, maybe they can be okay. But just know when I'm giving a beta blocker, usually I'm trying to get them out. Like if I'm giving a beta blocker because someone has a really high heart rate, I'm not giving it to get it super low. I don't want it to go to the opposite end. So once I have a patient's heart rate start getting into the 50s, like some people can be okay 55 to 60, but once I'm getting below 55, I'm kind of like, ooh, like, how we doing? Like, because most people, unless again that you're really in shape or you're sleeping, they need more than 55 beats per minute. So that's kind of like, the cue in my head once it starts kind of getting below 55. So especially with these meds. So it's not to say, so like, for example, let's say that my patient's heart rate was 70, and then I gave a beta blocker and it went down to 57. I wouldn't be concerned to be like, oh my God, there's a real problem here. Like there's an issue because their heart rate was above the parameters when I gave it, and it's doing the intended effects. But let's say that I gave a beta blocker, the heart rate was 70 when I started, and it went down to 52. I'd be a little worried then. That's a pretty steep drop. And so I'd maybe be talking to the doctor about the dose or, other things. And same with digoxin too, is that digoxin can also lower that heart rate. We'll talk more about digoxin in the heart failure lecture that's coming soon. So with this rhythm, not treatment is not always needed. Again, sometimes it can be normal, sometimes it can be expected because of the medication, but let's say it's not. Let's say it's a problem, because you have to remember, again, why would a low heart rate be a problem? Going back to all those annoying things that I talked about when it comes to like talking about blood pressure, cardiac output, is that it all comes down to, if my heart is beating super slow, I have less output. So like normally the heart's beating at a pretty steady pace. And so getting blood out. But let's say it's a little slower, so it's working slower now. So it's still getting blood out, but it's going to be getting blood out slower and slower, or less. It's going to have less opportunities to get blood out. So that's where we worry about bradycardia. And like I said, for many people, once we start getting into the lower 50s and stuff like that, most people are not feeling great. If you want to know what, we'll talk about this a little bit later, but, most people that are having issues with dysrhythmias, but especially for sinus bradycardia, what a lot of people can present with is they can present with what's called syncope, or they can be very lightheaded, dizzy. And so that's maybe what you would expect in a patient who's not tolerating it. So, most of the time, if like what I want to do is I have a patient that is sinus bradycardia. One of the first things I want to do is see how they're doing. How's their oxygenation? How's their blood pressure with this? How are they feeling? Do they feel lightheaded and dizzy? Did they pass out? Did anything happen that would make me think that they're not doing okay? And if they're not, then we have some medications we can give. And I'll tell you, I know you're going to be so glad to hear this. You don't have to know many medications for dysrhythmias. Like, we're not going to go deep into the treatments. You do not need to know. So that's why I actually took them out. So if you look at some of my older videos, you might see some of the drug names in, because I used to teach them all. But now I try to stick to like just the basics and what you really need to know at this level. But no, there are medications that we can give in emergencies. And then really I would say the mainstay hallmark go-to treatment for sinus bradycardia that's symptomatic. That is, and that's the key here, is if symptomatic. It's not saying you always have to treat this. If symptomatic, it's going to be a pacemaker. So let's talk more about pacemakers. So pacemakers, effectively, I talked to you before about that sinus node. That is the pacemaker of the heart. And what can happen sometimes is if that pacemaker isn't working right, and this can happen for a variety of reasons. It can be congenital reasons, unknown reasons, injury, other things like that. I had a nurse that I worked with that she was very healthy and everything like that, but her something went wrong with her regular pacemaker in her heart. And what I mean is like her heart's natural pacemaker. And so she was having these like dizzy episodes, and they found out like she was just chilling with the heart rate in like 35, 38, 39, like, all the time when she was on the floor as a nurse. And so she ended up needing to get a permanent pacemaker placed because of that, because there was, her pacemaker in her heart wasn't working. When you think of a pacemaker, you usually want to think about that this is, you can think of a pacemaker, it's making the pace of your heart happen. So it's used to speed it up. It is increasing the pace of your heart, if you want to look at it that way. Now, it is true that pacemakers, they have new fancy ones and things where they can slow down rhythms or, kind of help with that as well. But when we talk about a pacemaker, we're usually talking about a typical pacemaker. It's not used as much to slow rhythms down as it is to speed it up. And what happens is that the pacemaker, regardless of the type of pacemaker, it has like a set rate. So, and do you want to think I'd probably set, this is like, I'm pretty much trying to replace the pacemaker in the patient's heart that may not be working. And so usually we're going to have it be somewhere in that normal rate. And remember, a normal heart rate is like 60 to 100. Usually for most of these patients, because they're symptomatic having issues, we're going to usually put it around like 70 to 80. What he called is what we're going to usually have these pacemakers set to, but the doctor will make that decision. There's different types of pacemakers. I'll show you some pictures of these. There's transcutaneous or on the skin. There's transvenous or through the blood vessels. Epicardial, which is usually used after heart surgery. And then the type you really want to be focused on is the permanent pacemaker. And then for heart failure, we'll talk a little bit about biventricular pacemakers, which to keep it simple, effectively, it's a pacemaker that has leads on both parts of the bottom of the heart, or both ventricles, I should say, and it helps them to sync or work better together, because sometimes in heart failure they get out of sync with one another. So it helps them to work on their rhythm. So kind of think of it like if you had a part, what do you call it, like I don't want to call it like a seesaw. I'm trying, like maybe if you worked on like an assembly line and you have to do your part before the other person can do their part. It's just kind of figuring out a flow or a sync. So it's the same like what this is doing for the heart, is finding out a flow or a sync for the ventricles so that they're pumping more effectively in the right rhythm with each other. That's as much as you need to know about that. There's also what's called an ICD, and I do think it's helpful to talk for a second about what the difference is between a pacemaker and an ICD. So a pacemaker, again, mainly serves to keep your heart beating at least so many beats per minute. So we're trying to increase slow rhythm, and we're trying to get it so that it's at least beating so fast. So, trying to increase that cardiac output. Most pacemakers, don't serve, again, to do anything with the fast rhythms. They can't really sense or detect life-threatening rhythms. They can't sit there and be like, ooh, this is VTAC or anything like that. And they can't shock you. An ICD does is that the primary purpose of inserting one of these in, and these are usually inserted in patients that have had a sudden cardiac death, VTAC, VFib arrest, which we'll talk about those rhythms, but they've had a deadly lethal arrhythmia, or they're super high risk, like they have cardiomyopathy, or heart failure, things like that. And so with ICDs, they're on the opposite end of the spectrum, where they're like sitting there and saying, okay, what's going on? Is this heart pumping or not pumping? Is the heart electricity, working the way that it's supposed to? And it can actually detect when you go into lethal rhythms like VFib and VTAC. And then when you go into those rhythms, it can shock you. And so it is like an implantable cardioverter defibrillator. So it can literally get you back to life if your heart stopped. And I don't want to say your heart stopped, but if you went into a lethal rhythm. And so, I usually tell the story for the patient that I had when I was on a tele floor doing monitor tech job back before I was a nurse. And this patient had an ICD that kept firing, and it kept firing because the patient was going into VTAC all the time, which is not ideal. They really shouldn't be going to VTAC all the time. This is like a rescue device, but really, again, they shouldn't be going into VTAC all the time. So this patient, the defibrillator tells it it's about to shock them. So that way, if they're driving, if something's going on, that they have like a warning, they can pull over, they can, they can, stop what they're doing, sit down, because you don't want to be shocked, obviously, when you're sitting up. But it does hurt, because like literally it's a shock. And there's, most of the time when you're alive and getting a shock, you are, sedated and stuff like that. We'll talk about sorry. Hey, stop. 1 second. Sorry, my cats are fighting. Hold on 1 second. I'm gonna have to pause and separate them. Sorry for all the cat drama. This is why I don't like doing this so much at home, but sometimes you got to do it when you got to do it. So I apologize for the interruption, but like I was saying, the ICD can help to detect and tell when you're in a rhythm, but it's going to shock you. And so I'm not saying that you're like, if you're in VFib, you're not going to have a pulse, so you're just going to pass out anyway, probably not going to feel it. But if you're in VTAC, like this lady was, like she kept getting a warning. So I was sitting up at the desk, and like then I would hear her saying, oh no, it's about to shock me, like, because she knew it was coming. And I could see her, like I saw on her monitor, I saw her going into she was in VTAC. And then she's like, oh God, here it comes. Oh no, like, because it kind of gives them, I don't know exactly how it gives them a warning. It's either a sensation in their skin, a sound, a noise, or something else where they know that it's about to happen. And she was like, here it is. Oh my God, here it is. And then she'd just be like, ah, every time. And it kept happening multiple times one night. It just felt so much for her, because every time down the hall, like I would hear, like before, like I would even notice it on the monitor because it would happen. It happened so quickly for her, where she'd be like, oh, here it is. Here it is again. Oh no, here it's coming. Oh my God. Ah, like, every single time. So, needless to say, it is very interesting what, people come up with, how they created a device like this, Lord knows, but someone who's very smart. Needless to say, ICDs can do the sensing, detecting, and shocking, but they also can function as a pacemaker as well. They do have that function if needed, can be used. Let's try again. I think I'm just drawing here now. All right, there we go. So here's pictures of the different types of electrical devices that can be used, like permanent and other pacemakers. So I want to say, let's see which one's which here when it comes to some of these. Lead and right atrium, lead and right ventricle. So I can tell you about some of these. So first, let me, what do you call it? Because I always, it moved around. I updated my PowerPoint, so now everything's moved around. So this one here is what we call transcutaneous pacing. So I'll put TC up here, transcutaneous pacing. And so transcutaneous pacing is, as the name alludes, it's trans is across and cutaneous is the skin. So it's on the skin pacing. Now, we only do this if a patient, like, it's an emergency situation and we cannot, get their heart rate up. And, we're going to try meds and stuff like that. But sometimes in the meantime, we have to apply these pads and everything like that. Just to help to save their life. Now, this is going to give them little shocks constantly. I don't want to say shocks. It's going to give them a stimulus that's going to feel like a little shock pretty regularly, because it's literally trying to force their heart to pace. So usually these patients are either not going to be awake, or if they're going to have to be awake, then we want to try to consider that they may need some sedation or something else, or something to help calm them, because it can be painful. But it's through the skin pacing, usually only used in emergencies. Down here, this is epicardial. So I'm going to put EP or epicard, or maybe I'll do EC, epicardial. Epicardial pacing, this is when they have wires on the outside, that we use this to effectively what do you call them? If someone's had heart surgery and they're more likely to have dysrhythmias afterward, when they're in there, they go ahead and put the wires right on the heart, just to for more efficiency. And then after a few days after they've had surgery, they have this special stitch that they had put in with those. They literally pull it and it will take those wires off without hurting the heart. So it's amazing stuff what they do. Up here, this one is going to be our transvenous. So it's in the venous system, so you can go in through, and it would usually be on the right side. Sorry, it looks like the right. This is actually my right, because everything's reversed. But it goes in the right side. And the internal jugular, you can also go up through the groin, and it goes directly into the heart, almost like a catheter into the heart. Well, it is a catheter, it's a pacing catheter in the heart, and effectively helps to send signals for pacing. So we do this when someone maybe needs a permanent pacemaker, but they're not stable enough to go and get one right now, but they need something a little bit more than what we're ever giving them with medicine. So we don't have to keep transcutaneously pacing them. We can do this short term. We don't like to do this long term. We don't do this long term. All right, so I think I figured the other ones out. So this one, oh no, this one. This one looks like the CRT, it's what's known as CRT, or cardiac resynchronization therapy, or the one that's used for heart failure. It's that dual biventricular pacemaker. This looks like that because it's on the outside with the ventricles. So this is a biventricular pacemaker that helps in heart failure to sync things up. This is just a regular permanent pacemaker. So I'm going to just put PP for permanent pacemaker down here with my Harpo handwriting. And so you can obviously see where they're implanted. They're implanted up in and I keep wanting to do like the opposite, but yeah. Oh yeah, no, it is right. Yeah, left chest usually, when possible, is the preferred place. And then down here is an ICD. You can see it's implanted in the same place. Just has those extra leads for shocking. So this is all fine and interesting, and hopefully it helps to give you some information that will make sense when we talk about what are we going to do as the nurse when it comes to pacemakers and ICD teaching. Because again, we're not going to give you a picture of one and say what kind of pacemaker is this, but you do need to know what teaching is imperative for these patients. So for pacemaker teaching, we want to teach them to monitor their pulse. This is if they just have a pacemaker, and let the doctor know if it drops, which means that when they go home, they have to be taught to how to take their own pulse. Because remember, this device is supposed to keep their heart rate above a certain amount of beats per minute. So if it's not keeping them above so many beats per minute, then it can definitely lead to, a sign that the device is not working. So with pacemaker with the with the teaching about the pulse, I want them to make sure that they recognize what their pulse is supposed to be, and then when they need to call. And so again, it depends on what it's set to. The doctor should be able to tell them what their pulse should be or what they should expect. But you need to teach them how to check their pulse. Again, the doctor will clarify exactly what number to call for. Specific ICD teaching is that if their ICD fires, it's not like, oh, hey, yeah, yesterday I was at this barbecue and my ICD fired, but I'm good now. Like if my ICD fired, that means that I'm having a lethal dysrhythmia. I need to go to the doctor immediately, get help, 911 if I'm out and about and don't have someone who can drive me there. And then if someone already has an ICD place, most likely their caregivers probably are going to need to learn CPR, because even let's say that it shocks them, it may or may not restore circulation for them. People need to know how to do CPR that live or in close proximity to this person, because they're very likely to have a sudden death. General teaching that we want to do for both pacemakers and ICDs. This is more like post-operative and general teaching. We want them to look for any signs of infection, teach them about, purulent drainage, watching the incision for redness, tenderness, that kind of stuff. This is a really big one. Avoid lifting or trauma to the affected shoulder. Like most people, of course, yes, I know the next one says direct trauma or injury to the site. Like we don't want anything pushing right up on where that pacemaker is tunneled under the skin, but also the shoulder on the left side, we have to be super careful with it. We don't want them lifting above. We don't want them doing any pushing, pulling. They're going to have a weight, limit that they're allowed to lift after surgery. And this is not in place forever, but usually for a period of a couple weeks, they have to be super careful. After patients get out of the surgery, we actually usually have them in a sling. And so that's just to protect them from, forgetting that they're not supposed to be doing a lot with that shoulder. A common misconception is that people with pacemakers cannot use a microwave, and they absolutely can use a microwave. That's just a common misconception. And then they are okay. Most households, like appliance level stuff, pacemakers, ICDs, both okay. Both of these devices can set off metal detectors. So if they're at the airport, train station, where if they're going through any metal detector, they're going to Taylor Swift concert because they're lucky and they got those tickets. They want to make sure to, always, let people know they might need to do a handheld one, just because they are going to set off that metal detector. The wand or whatever it is, what I meant for that. MRIs, they can sometimes get MRIs. A lot of the new pacemakers are MRI safe. But what we always do, for any device that's on a patient, this could be like they had a knee replacement or they have a pacemaker, MRI actually will call or check with the manufacturer and see if it's safe, or they'll look in the manufacturer's, like the model number, and look it up. And they can get the information of whether it's MRI compatible. There are more that are compatible these days, but there's a lot that still aren't. So just keep in mind that. And they don't want to get the incision wet. So no swimming or, soaking. They can obviously take showers. But usually we, like no soaking or, putting the whole incision underwater is a good idea. So I'm seeing here real quick. Yeah. I'm going to stop here. And I will do a really quick short on paced rhythms just to split this up. So this is a whole, everything for sinus bradycardia effectively. It can be normal. There are times that it becomes abnormal. If it's symptomatic, then we're going to need to treat it. I'm not going to, like I said, I'm not going to go deep into the medications, but there's continuous drips we can put them on. And then, you know, the med that you're going to hear a lot, not on our test, but if you hear it in the future, is what's called atropine, can be used to speed up the heart. It's a temporary band-aid, though. It's not a perfect permanent fix. We have to get to the bottom of whatever the problem is. So also, that's one thing I don't have on the slide, but something to keep in mind is that for sinus bradycardia, you always have to get to the bottom of the cause. If the cause is their pacemaker's not working, they probably need a pacemaker replaced. But if the cause is, hey, they're taking too many beta blockers, not too many, but like too high of a dose, then maybe we need to get to the bottom of that. So always look for what the cause is. And yeah, then if they have to have a pacemaker placed, make sure that they know about all of the precautions they might need to take. And then, like the special, like how to, take their pulse, things like that, and general management post-op. That's effectively sinus bradycardia, all summed up. Hope it makes sense. This is a longer one, but most of the other ones are going to be more short, sweet, simple, to the point. So hope this helped. I'll see you for the next one.